So why this picture is here? Because of his beautiful nose. Today we will discuss diseases of external nose. So in the end of this lecture, you should be able to solve these questions. 50 years old farmer presented with non-healing ulcer on the nose, non-tender globulated swelling over the tip of the nose, diagnosis, newborn presented with cyanosis relieved by oral airway, tender swelling of nose tip with fever, unilateral nasal obstruction with mass in the nasal cavity since birth. So you should be able to solve these questions. So what is external nose? External nose has bony part and cartilaginous part, and it is covered by skin, and bone and cartilage are united to each other with the help of musculatures and ligaments. These muscles are to dilate the nares. So procerus nasalis, levator labii, dilator nares, and depressor septi are the muscles. So this is cephalic part of nose and this is caudal part of nose. Whenever you are describing any disease, you can say it is present on the cephalic part of nose or it is present in the caudal part of nose. This is anterior, this is posterior. Okay, this is tip and this is root of the nose. This point is the columella. Okay, and this is philtrum and nasolabial angle. This angle is the nasolabial angle and this part is called philtrum. And this is columella. These openings are called anterior nares or nostril. Okay. At the side of these ala, there is groove called alar groove. Okay. So this part is the bridge of nose. This is root, this is tip, bridge of nose, anterior part, posterior part, cephalic region, caudal region. Okay. And this membranous part is called columella. And this angle between upper lip and nose is called nasolabial angle. So bony part form the upper 1/3 and it is formed by nasal cartilage, nasal bones. Cartilaginous part is formed by two cartilages, upper lateral cartilages and lower lateral cartilages. Okay, lower lateral cartilage form the tip of the nose, ala of the nose. Okay, and it is deficient posteriorly at this region. So inside the nose, both caudal regions of septum and lateral walls are lined by skin, and this region is called vestibule. Most caudal region of septum and lateral wall is lined by skin, keratinized skin, and it is called vestibule. Okay, so here are present in the vestibule. So boil is common only in the caudal region of the nose, either in the septum or on the lateral wall. So two nasal cavities, bone is internal nose is divided into two nasal cavity with the help of nasal septum. So nasal septum, we will read the anatomy of nasal septum with the diseases of nasal septum. It has membranous part and cartilaginous part. On the lateral wall, there are turbinates. You can call it as coena, concha. Okay, so but we call these concha turbinates. There are three turbinates: inferior turbinate, middle turbinate, and superior turbinate. The space beneath this turbinate is called meatai. So roof of nose is formed by cribriform plate in the center and laterally by fovea ethmoidalis. Adam,
Yes, ma'am.
what is vestibule?
Ma'am, it's the lower cartilaginous part, the caudal part of the nose, and it's
Where,
formed by.
on the septum or on the lateral wall?
It's on both. It's on sub
Both. Okay.
and
So what is why this part is important for clinically?
because this part has hairs and can
Hairs, and
or-
there can be infection of hair follicle that is called boil. So boil will always be present in the caudal part of nose. It can be on the lateral wall or it can be on the septum. Okay. So you can see these are the turbinates, inferior turbinate, middle turbinate, and superior turbinate. Beneath these turbinates are the spaces called metae. Okay. So roof is formed by cribriform plate in the center and laterally fovea ethmoidalis. Now, what is the epithelium of nose? There are three types of epithelium inside the nose. Caudal region lined by skin, so keratinized squamous epithelium. Beyond this skin, lining of nose is respiratory epithelium, that is ciliated columnar and or the ciliated cuboidal epithelium. Then superior part of nasal septum and superior part of lateral wall, and the roof is lined by olfactory epithelium. This epithelium contains nerve endings and it is important for smell, important for olfaction. Okay. So sometimes there is degenerative changes in this olfactory nerve endings due to some viral infection. Most common nowadays is coronavirus. So patient can present with anosmia or anything that is causing complete obstruction of nasal cavities, such as polyps, marked DNS, marked inflammation due to allergy can cause anosmia because it obstructs the air entry into the nose and air cannot stimulate the olfactory nerve endings. Okay, so anosmia may be due to degeneration of the nerve endings or due to complete obstruction of the nose. Okay, so blood supply we will discuss with the epistaxis, and you read yourself the nerve supply of the nose and lymphatic drainage. Most of the anterior part is drained into anterior cervical lymph nodes and the posterior part into retropharyngeal lymph nodes. Then it goes into deep cervical lymph nodes. So this is nerve supply. You can see this olfactory nerve endings supplying the roof of the nose. Then development of nose is important because there are certain developmental anomalies. Child below 2 years can present with these anomalies. So nose develop in third week of fetal life. There is olfactory play cord, and this depression later on it will form cranial ectoderm, and invagination of this play cord will form two tubercles, medial tubercle and lateral tubercle. These two medial tubercle meet together and they will form maxillary process or premaxilla. And this lateral tubercle will meet with the mandibular process and will form the cheek and the lower part of face. Okay, so developmental anomaly will be failure of fusion of these tubercle, may lead to cleft palate and cleft lip, cleft lip. So other developmental anomalies are dermoid cyst, meningocele, meningoencephalocele, and nasal gliomas. What is dermoid cyst? Dermoid cyst. What is dermoid cyst? Adam? Mishal, what is dermoid cyst?
Ma'am, it's a congenital tumor.
Congenital, it is invagination of dermis inside the Fujian lines, okay? Where the two processes meet to each other and there will be invagination of dermis. And this invagination later on will present with cyst, and this cyst can have connection with the, like this, can have connection with the intracranial cavity. Sometime it is present externally, sometime it forms sinus over the skin. Okay, so it may present with sinus over the bridge of the nose, swelling over the bridge of the nose. If this swelling increases while patient is coughing or crying, it means it has some intracranial connection, like in this. Okay. So CT scan and MRI is mandatory before removing the dermoid cyst, because if you are removing it and you are not sealing the meninges, there will be CSF rhinorrhea later on. Glioma, what is meningocele, meningoencephalocele? There is herniation of meninges, is called meningocele. Herniation of meninges along with some tissue of brain is called meningoencephalocele. And brain tissue, if it is present in the nasal cavity, it can form glioma. So important is choanal atresia. You may have might get question from choanal atresia in MCQ questions, and sometimes it is asked in table viva. So during development, both nasal cavities are filled with epithelium. Okay. Later on, there is absorption of this epithelium, that is called decanalization. Decanalization. Failure of this absorption of epithelium or failure of decanalization will lead to some obstruction inside the nasal cavity. Okay, so this obstruction can be unilateral, can be bilateral, can be membranous, or can be bony. Okay, it is called choanal atresia. It is usually present in the posterior part of nasal cavity, near the posterior apertures of nasal cavity. Posterior apertures are called choana. So failure of decanalization at this part is called choanal atresia. Okay, it can be unilateral, bilateral, can be membranous, can be bony, and usually it is associated with some syndrome that is called Charge syndrome. Okay, in Charge syndrome, there is C stand for coloboma, splitting of eyelids. H for heart anomalies, A for atresia choana, R for retardation, G for genital problem, and E for ear problem. Okay. So patient can present with hearing loss or microtia along with choanal atresia. It is life-threatening condition if it is bilateral. So if patient by birth is having bilateral choanal atresia, bilateral obstruction of nasal cavity, patient will present with severe cyanosis and respiratory distress. And when you will put airway in his mouth, patient will start breathing. So you can assess that problem is in the nose, and when you are bypassing this obstruction, breathing gets normal. Okay, so it is diagnosis of choanal atresia. Immediate after birth, if patient is presenting with cyanosis, and this cyanosis is relieved by putting airway in the mouth, you are bypassing the obstruction. That is diagnostics test for choanal atresia. Other examination, you can pass catheter through nasal cavity if it is inside. If you are failed to see this catheter in the oropharynx, it means there is obstruction. Fogging, because air is not entering into the nasal cavity, there will be no fogging of mirror. Then with the help of endoscope, telescopes, you can see obstruction in the choana. Auscultation, you take stethoscope, and with the help of stethoscope, you can try to listen the respiratory sounds in the nasal cavities. All these are not 100% diagnostic, but CT scan and MRI are the 100% diagnostic test for choanal atresia. So while you are suspecting choanal atresia, you will advise CT and MRI. CT and MRI will give 100% diagnosis. So treatment is the removal of this obstruction. How? You can do it with the intranasally, or other approaches, transpalatal approach or endoscopic approach can be used. Intranasally, we can do it with the help of endoscope, that is called FES, or endoscopic sinus surgery or endoscopic approach. Okay. Then disease, it is very important. Boil of the nose, you might get MCQ, you might get scenario, and this is really asked in your OSCE and in table wire. So what is boil?
Inflammation of hair follicle.
Chabas. It is Staph aureus infection of hair follicle. Okay, infection of hair follicle caused by Staph aureus bacteria. So if it is recurrent, patient may have diabetes. So you will have to investigate diabetes in those patients who are presenting with recurrent boil. It is highly painful condition, and one life-threatening complication of boil is cavernous sinus thrombosis, because drainage from this area goes directly to the cavernous sinus, and these veins are without valves. Okay, so absence of these valves can cause direct infection from boil to the, can spread direct infection from boil to the cavernous sinus, and there may be cavernous sinus thrombosis. Other complications, if you are not treating by boil and there is spread of infection, so infection can spread to septum, causing septal abscess, or there will be inflammation of whole vestibule, that is called vestibulitis. So patient will present with tender swelling near the tip of the nose, whole nose may be swollen, there may be swelling of the cheek that is associated with this boil, and there may be sometimes nasal obstruction. If boil is large or infection is spreading towards the septum, there is septal abscess, so patient can present with severe pain and nasal obstruction. So you will choose antibiotic that is best against Staph aureus infection. So best antibiotic is combination of amoxicillin and clavulanic acid, that is co-amoxiclav. Because Staph aureus are the bacteria that can secrete beta-lactamase enzymes. So clavulanic acid is against this enzyme. If patient is sensitive to penicillin, then you will give cephalosporins. If there is abscess, then you will drain this abscess. Okay. One disease is rhinophyma, that is disease of sebaceous glands. There is hypertrophy of sebaceous gland, and you can see this disfigurement of the nose due to hypertrophy of sebaceous gland. Okay, it is painless, but it can cause cosmetic deformity, and treatment is excision. Laser excision is best for this. If you don't have laser, then you can excise this above the cartilage. You can peel it over the cartilage. Then benign and malignant tumor. Benign tumors are papilloma, that are warts, hemangioma, neurofibroma. Malignant tumors, most common tumor is basal cell carcinoma, then squamous cell carcinoma, and malignant melanoma. Malignant melanoma is rare, but it is highly malignant tumor. Basal cell carcinoma is the commonest tumor of skin, and squamous cell carcinoma is the commonest tumor of head and neck region except skin. These are your MCQ questions. Malignant melanoma is rare, but it is highly malignant tumor. Okay? So if MCQ is most common skin tumor, what is that? And FIFA, what is commonest tumor of head and neck region?
Squamous cell carcinoma.
Squamous cell carcinoma. And which tumor is the most malignant tumor out of these tumors?
Ma'am, it's malignant melanoma.
Malignant melanoma. Okay. So these are your MCQ questions. So basal cell carcinoma is usually locally malignant tumor. It erodes the skin, erodes the deeper tissue. It can involve the cartilage and bone and can go inside the nasal cavity. Male and female ratio is equal. Usually it is seen in old age and usually seen in people who are working in farms, usually seen in farmers or in sun exposed areas. Usually it is seen over the nose, bridge of nose. Nodal metastasis is rare. Slow growing tumor. So treatment is surgery and reconstruction. Surgery, you will remove the tumor along with some healthy margins, and reconstruction. This raw tissue will be replaced by healthy skin and graft is taken from other part of the body. You can see this basal cell carcinoma over the bridge of the nose. Then squamous cell carcinoma, most common malignant tumor of head and neck region, and second most common tumor of skin. Okay, so patient can present with non-healing ulcer. Let's patient is presenting with non-healing ulcer. Margin of this ulcer will be raised. Nodal metastasis is seen, and nodal metastasis is more as compared to basal cell carcinoma. So how will you diagnose any non-healing ulcer? In cases of any non-healing ulcer, how will you make diagnosis? You will take proper history, then you will take tissue from the ends of the ulcer. So histopathologist will tell you what is this, basal cell carcinoma, squamous cell carcinoma, or malignant melanoma. So diagnosis is made by biopsy. So treatment of choice is squamous cell carcinoma is removal and reconstruction. And if there is lymph node metastasis, you will have to do neck dissection. You will remove all the lymphatic drainage of that area. So in early stages, radiotherapy can also be given. Malignant melanoma usually present with ulcer and nodal metastasis. So any question? Any question? सुना भी है लेक्चर या ऐसे ही? Years old farmer presented with non-healing ulcer on the nose. How will you make diagnosis?
बायोप्सी करके हम लोग इन्वेस्टिगेशन में बायोप्सी करके कंफर्म करेंगे कौन सा है, और फार्मर्स में मेनली बेसल सेल कार्सिनोमा इज मोर.
क्या करेंगे over the bridge of nose? How will you diagnose? Related swelling over the tip of nose, that it can be some tumor, can be cryophyma. If globulated swelling over the root of the nose, it can be dermoid cyst, okay, or any congenital anomaly, gliomas, okay. Newborn presented with cyanosis relieved by oral airway. Newborn presented with cyanosis that is relieved by oral airway.
Spinal atresia.
Shabash, choanal atresia. Tender swelling of tip of nose with fever.
मैम बॉयल होगा.
Nasal obstruction with mass in the nasal cavity since birth. Unilateral nasal mass is the unilateral congenital nasal mass. Can be glioma, meningocele, meningoencephalocele, because it is present by birth. Okay.